Well, it's really my pleasure to be here. Thank you so much. I'm glad to be here, and thank you for staying. I'm going to be really talking about women throughout the life cycle. My first objective is to really recognize that research in women and HIV has been groundbreaking and profoundly influenced our understanding of how we treat both women and men. And that's a theme that kind of weaves throughout this talk. You'll see a lot of our understanding of HIV and how we can treat it and prevent it comes from research based on women. So we get to put a pat on our backs for that. I also want to identify the role that female gender-based research has played in really understanding more about the modern paradigms of how we treat, transmit, and prevent HIV. And finally, I want to highlight the care and research that's available here in our two programs that really work together. And that's the NMH Women's HIV Program and the NMH Perinatal Program. So the next 4 slides are just to make sure everybody's on the same page, because not everyone sees HIV every day like I do. I want to make sure that everyone's really aware that women get HIV therapy primarily through heterosexual sex, and it's a huge problem worldwide. In the pandemic of greater than 30 million persons throughout the world, about 50% of those cases are women. So that's not our epidemic. Our epidemic is more like 25% of HIV in the United States is women, but worldwide, it's half and half. This is a recognition that our Women's Perinatal Program gets patients from all over the world. Women come from each continent. I don't think we've gotten anyone from Australia yet. Come to Chicago area because they know if they reach here, they'll be able to have an HIV-free baby. And so we get a lot of women who leave their families or come and stay with one cousin, maybe a second cousin, to be able to come here and start a new life and get the therapy through a program like ours, or through the other programs that are throughout the city. There are about 4 or 5 other programs that are referral centers for HIV and pregnancy throughout the city. That's good to know. I just threw up this, the slide of the natural history of HIV infection. Luckily, a lot of our patients have this natural history interrupted. But the point I wanted to make is the horizontal line is based in time, and it's years. It takes years to go from acute infection to dying from AIDS, and that huge long period in between is called the latency period. That was a name when we realized that there were years that people didn't get PCP pneumonia, or didn't get MAI infection, or didn't waste away from diarrhea. But now we know that same period is dangerous for individuals to have unobstructed, unopposed HIV infection. Now the recommendation is that everyone who is diagnosed with HIV should get started on therapy as soon as possible. But it still carries that name of being asymptomatic latency, but there could be damage to organs like lungs, liver, increased risk of malignancies, as well as increased risk of getting tuberculosis and pneumococcal disease well before you're in that danger period of having a CD4 count below 200. I threw this case together. It's a very simple and sad case, and it came to us a few weeks after the diagnosis. This was a woman who was 22 years old. She was African American, and she lived in Austin. She was newly married, and she was pregnant. It was her first prenatal visit where she was tested for HIV, and that's by Illinois law, and her HIV test was positive. So the next thing that happened was she got referred to us, and we saw her very quickly after that, within a week. But her history was significant. She had 2 male sex partners in her whole lifetime. She was only 22. And at age 17, she had had that first sex partner. Her present husband, the one she'd married just a year before, He was HIV negative. She was not an IV drug user. She had no other transfusions. There wasn't any big, long mystery to this. It was her first partner, sex partner, that gave her HIV. And where, yes? Where was she from? She was born in Austin, which is right next door to, really to Oak Park, Illinois, where I happened to live for a while. So the three questions that pop up in my mind are, what's a provider to do? As I said, many in the audience may not see HIV every day like I do, but I have a simple answer for that, and that's on the next slide. The next thing is, how did this happen to her? The simple answer is she was at kind of wrong place, wrong time, wrong first boyfriend. The third is, what does the patient need to know? What messages can you, the first provider giving the news, can you give? What can you say to her as her life is flashing before her? So what's a provider to do? The first thing is Google Illinois HIV perinatal, and out comes this information. This is the 24/7 Illinois perinatal HIV hotline. There's a phone number, there's a phone number as well, and a website. But once again, Google is our best help there. This is a hotline that provides services and resources to the whole state of Illinois, and we're part of that. And actually, the hotline originated here at Northwestern. On there is a lot of resources for individuals and for hospitals, perhaps who find a patient who's in labor and has a positive HIV test that you didn't know about, or you're asking that question, who should I call first, what should I start, or just who can see this patient really, really soon because the patient's pregnant. So this has an overarching design of the Illinois approach to preventing babies from getting HIV. First, as I mentioned, there's the 24/7 hotline, Illinois hotline, and on top of that is the enhanced case management and referral system. So when you call that hotline and say, I've got a pregnant woman, she's got HIV, I don't know what to do, somebody will get on that line and call a case manager who can go to that patient and visit with that patient or talk on the phone and gives a lot of reassurance. So even you, the provider, you're not alone as well. The second thing is that referral will happen rapidly to a referral center where professionals are used to seeing HIV in pregnancy and will welcome that woman and give a lot more reassurance after you've given the initial messages. The underlying issue about our wonderful nature of the system of Illinois' approach to preventing HIV in pregnancy is that by law, every pregnant woman on their first exposure to a healthcare system is supposed to get screened for HIV. And that's a wonderful thing. It's also a sad thing because we should be screening our universally, and we don't do as good a job as we've done with our pregnant ladies. So this is a wonderful picture from a recent fundraiser that we had. The Hope Board is a team of community leaders who raise money to provide services for our clinic. In the center in the white blouse and black is Pat Garcia, the leader of the perinatal program. I'm next to her, and then we have a wonderful combination of maternal fetal medicine specialists, pharmacists who are specialists in infectious disease and actually in giving HIV therapy to pregnant women. We have our psychologist, and we have our nurse coordinator who really keeps our clinic running and keeps it together. Finally, we have our social worker who is in pretty much constant contact with so many of our pregnant women or our postpartum women who have such high needs during this time. What our clinic performs as kind of an amazing coordination of care, including diagnosis, confirming diagnosis of HIV, instituting treatment, preventing transmission to partners and to the babies, and definitely teaching the next generation. Our second issue that arises from from the case that I mentioned is, how did this happen? And it's a really complex answer. I mentioned wrong neighborhood as part of the answer before. Look at this map. It's a kind of an amazing map. It's a distribution of where HIV is in our Chicagoland area. In one neighborhood, perhaps slam right next to another neighborhood, there might be 40 times different amount of HIV depending on what block you live on. That's kind of shocking. I want to note that Austin, I think, is area number 26, right next to a dark blue area, an area of most concentration, right straight out the Eisenhower Highway. So I said there's some things that I want all of us providers to know, to be able to give to that woman when she just found out, you just told her she has HIV infection. I want you to be able to give her some reassurance that she has the potential for a normal lifespan. I think a lot of people still have the image that, oh, I'm going to be dead in 7 years. I won't see my kid grow up. The key to that I want providers to give is the key to that is taking your medicine every day. So right from the start, the message is long life is linked to good adherence to HIV medications. And if she hears that consistent message from every provider all the way along the line, it's going to make a big difference to her. She's worried for her own life. She's worried about the risks to the baby. She's worried to the risk to her relationships, both to her partner in life and perhaps her extended family, to her community. Things that you can tell her are that with appropriate care for HIV, it's incredibly likely that she can have an HIV negative baby. So this is HIV prevention at its best. Indeed, also, research has shown that we can dramatically reduce the risk of transmission horizontally to a sex partner, and that there can be a rich sex life with HIV. So the big message is reassurance, education, and long-term support are linked with long life. So I want to touch on the classic modern paradigms that we have, that we throw around in HIV clinic all the time. But these are fairly modern ones. They've accumulated over the last few years. First, no surprise, transmission is associated with a high viral load in the infected partner. The second paradigm, test and treat. If you find somebody has HIV, start them on treatment. That's the expectation. There shouldn't be an attempt to say, well, they're not ready yet. Try to start them as soon as possible. The third thing is we need to be screening everyone, regardless of risk. The CDC says begin that at age 16 and above. Everybody needs to be screened. The next thing, give heart to everyone with HIV regardless of CD4 count. And why? Because it benefits all patients regardless of their CD4 and their viral load. And here's a toughie. We have all these lofty goals, but the reality is we're not succeeding in getting HIV therapy to all the individuals that need it and deserve it. It's an immense challenge, and I'll be showing that in the next couple of slides. The next, treating the infected partner prevents transmission to the uninfected partner. And finally, the switch. Treating the uninfected partner with HIV therapy protects him or her. So this is a conference about sex differences. What do we already know? We know that male to female transmission through sex is more efficient than female to male. And why? Well, that we're not quite so sure, but I can tell you the facts as we know them now. With vaginal sex, women have an increased likelihood of getting HIV during sex without a condom than men do. Fact, anal sex without a condom is riskier than vaginal sex. In fact, during acute male seroconversion, semen is highly infectious. And we have a lot of theories, and some of the work is done here about trying to sort out what's really going on a cellular level and on a tissue level. So here's down and dirty about semen during seroconversion. And that is that most transmission is likely to happen male to female during acute seroconversion, perhaps when the infected person, the male, doesn't even know he has it. And that is that the increased odds, the concentration of semen is so high during seroconversion that it increases the odds of transmission from 1 to 400, which is the number we always comfortably say, through 1 to 400 acts of sex, down to 1 to 53. So I wanted to touch on how wonderful pregnant women's screening has worked across our state and across many other states. And that's to say that really with legislation, the OBs got behind the initiative to screen all pregnant women, and now that's really standard of care. And then later, the CDC decided that we all should be screened. A classic ACTG trial, the 076 trial, was the very first demonstration of treatment as prevention. They observed that high viral load appeared to be linked with increased vertical transmission, and they only had one drug. They started with AZT and they gave it to pregnant women, and the transmission rate dropped with one drug for the pregnant woman from 25% to 8%. Our lead of the perinatal clinic was Pat Garcia, was the first author of that paper. Later studies have really demonstrated that we can get that transmission rate way down to 1% or lower with combination therapy, the same kind of therapy that everyone gets. So you can see that there was a dramatic reduction in perinatal transmission. Now we have handfuls of infected HIV patients in the United States. So once we started using combination therapy, that risk of transmission is dramatically reduced, but that's only in patients who we identify and who can comply with therapy. I wanted to show some of the adherence tools we use routinely for HIV therapy, but how many people know of an HIV patient on 5 pills 3 times a day anymore? That's not very common. The more common program for HIV patients is 1 pill once a day. And so adherence, you'd think, would be very, very easy, but somehow that's not true. So why do we still have a handful of babies born each year with HIV? The same reason we have a number of people, particularly the poor or disengaged patients, who have a number of complex biopsychosocial factors that really get in the way of adherence. Some of the things that go on are lack of or delayed prenatal care. Lack of testing in pregnancy still happens, though rarely. Lack of linkage to care. Our hotline provides that linkage as quickly as possible. Seroconversion during pregnancy. Now the recommendation is to try to identify those who are at high risk and retesting pregnant women in 3rd trimester as well as first presentation. There's treatment failure, of course, and there's definite avoidance of care. There are patients even in our program who stay away from us, hide from us, don't answer their phones, lose their phones, go to another person's house for a month in order to stay away from us because they're having a difficult time complying with therapy. So I just wanted to touch on some of the things that we know about sex differences and HIV treatment. First, that we know there are differences between how men and women process drugs. For one dramatic case, we have a drug called nevirapine that we don't use that much anymore. But what we found is there were cases of hepatotoxicity, even resulting in transplant or death, along with rash. And the thought was, or the paradigm was, that an active immune system would increase your risk. And ultimately, sex difference-based studies have shown that it's safer relatively to give this drug as part of heart therapy when a woman's CD4 count is dramatically lower than a man's. Okay, so when their immune system is detuned and damaged, that's when you can use this drug more safely. That's not intuitively obvious, and it was only through research studying sex differences. There's also been considerable amount of study of drug-drug interactions. Some antiretroviral therapies interact with contraceptive methods and make each one of the drugs less effective. And as a consequence, there's the possibility of unwanted pregnancy and even of ineffective heart. My colleague Susan Cohn in the front row is involved in that and has been involved in that for years. There's also altered physiology, and pregnancy, of course, is the ultimate altered physiology. And we have many studies, including impact studies, that have studied the pharmacokinetics of how HIV drugs change, how the levels of HIV drugs change throughout pregnancy as your volume of distribution rises, as your blood volume rises, and as your liver gears up for pregnancy. The last thing is that we've been studying the long-term impact of HIV therapy on the drug-exposed babies. So these are babies who don't have HIV, but they were exposed to these drugs that act on DNA. And so what is the impact long-term on their mental and physical growth, intellectual growth, and bone growth, metabolic growth? It'll be very interesting to see. So those are some of the studies that are going on here at Northwestern. I just wanted to, 1 minute, touch on this incredible concept of the HIV cascade. And what's really amazing is that if you focus on the goal of getting everyone to undetectable viral load, there is a stepwise drop-off at each step. And this is true for men and women, and we need to understand better why women drop off at these different steps. Of particular notice, I want you to notice that between linked to care and retained in care is an incredible drop-off. So just knowing that you have HIV, knowing that you have a doctor who has met with you once, and has told you about the amazing thing that HIV therapy can do, doesn't mean that you're going to end up staying with it and taking it lifelong like we expect. That's the kind of research that we're doing here at Northwestern, and it's fascinating work to do. We do it together as a multidisciplinary team. We welcome any input from others about this complex process of keeping all types of women involved in care so that they can live to that normal lifespan and have full and productive lives. I think I'll leave it at that, but the workshop this afternoon will be focusing on some of the challenges of retaining people in care. So come, thank you.